Good afternoon, everyone. My name is Heather Miller. I am a healthcare transactional, regulatory, and operational lawyer with Nelson Mullins, and I work in their Boca Raton office. I've been moderating this conference for many years, and the excitement here today has really been wonderful. This is the last panel of the day, and it's on value-based care contracting from both an operational and a strategic perspective. And at the end, we'll pay a particular focus on payer contracting. And I can promise each of you that you will leave today with pointers that you can apply in your business. On the panel today, you have already met Juliet and Ed, and this is the first panel for Brantley Kilgore. Brantley is leader of strategic practice with Coker. He assists clients with physician alignment, payer strategy, and value-based care enablement. He has a wealth of experience in physician, incentive, and alignment models, and in developing payer strategies. He has been involved in forming over 50 clinically integrated networks and ACOs. The breadth of experience on this panel is very impressive, and I highly encourage you to stay until the end. I'll be posing specific questions that I think you will find very useful. Now, over the last decade, we have seen an evolution in value-based contracting, both from a provider and a payer perspective. The previous panels have given great insight to where we are today and some of the gaps in the VBC world and how we continue to grow in this space. To start this panel, I do think it would be helpful for someone on this panel to give the audience a primer on the evolution of value-based contracting. So I'll start with Brantley. Can you please tell the audience how the market has evolved from a value-based contracting perspective over the past 10 years?
Certainly. Thank you, Heather, and others feel free to jump in. I'll again maybe answer this from two lenses. One, how's the insurance market changed and evolved over the last 10 years? And then how have provider organizations responded and how are they positioning themselves over that time frame? So, certainly if we think about it from a line of business perspective, we've seen certain models, particularly in the traditional Medicare space, like Medicare Shared Savings Program and bundled programs, really solidify themselves as tried and true models. They've scaled, they have a very high degree of participation, and we really view those as stable contracting opportunities into the future. A huge change that we've seen over the last 10 years really centers on the Medicare Advantage market. At the passage of the Affordable Care Act in 2012, 27% of Medicare beneficiaries were opting into MA plans. In 2022, the scales tipped, and MA was then over 50%, now the predominant selection for Medicare beneficiaries. It's up to 54% today, and Kaiser projects that it's going to jump up to 60% by 2030. So that certainly brought with it certain challenges in the provider and payer contracting market, but I think the message is Medicare Advantage is here to stay. The commercial side of the equation has seen maybe a little bit slower growth. Juliet, you referenced some of the data and statistics in your opening comments. We do still see some growth in this space. We do expect there to continue to be growth, but it's just moving slower, and there are a variety of internal, strategic, and external market reasons behind that. Shifting our focus to the provider side of the equation and how that approach has evolved over the last 10 or so years. If you think back to, let's say, 10 years ago, we were really in this initial wave of adoption, early participation and experimentation. Most of the value-based contracting opportunities at 10 or so years ago offered upside only, allowed us to enter into and participate in these strategies in a safe space. If you flash forward to maybe the late 2010s, we started to see some of those early models start slowly moving more in the direction of two-sided risk. So this is really where, in my mind, our observation has been this is kind of the stabilization of value-based care. So certain lines of business, certain contracting opportunities remain high in focus, but not at the exponential growth that we saw early on. More recently, the industry has, from a provider organization standpoint, been dealt a couple of body blows in the form of a global pandemic that brought with it significant financial challenges and strained our healthcare system more than any of us have ever seen. And then more recently, we'll talk more about kind of the impact and the projections around the Big Beautiful Bill that are creating margin pressures and sort of external stimuli that are really forcing organizations to be selective and in some cases even contract or walk away from certain value-based contracts in certain lines of business that have not been as advantageous. So the long and short of it is in essence, what we've seen over the last 10 years is that value-based contracting models are exhibiting more and more risk. And because of some of the external factors and the existence or the more prominence of those risk elements in the contracts, we're seeing providers be a lot more disciplined in terms of how they pick and choose where to play in the value-based contracting space.
And Juliet, are you seeing the same thing in your experience?
Yeah, I would agree with all of that. I would also say that I think not just are the plans facing these pressures, but obviously that's rolling, whether you want to say downhill, uphill, however you choose to look at it, to the providers as well. And I think one of the most interesting things is that providers and provider groups have had to start to be smart contractors. And just as much as I think historically when we say selective contracting, we think of a health plan being a selective contractor, we're seeing more and more providers having the ability to say no to contracts.
Yep.
And so I think a lot of the dynamics that plans have typically had to live in or act upon, we're starting to see those same kinds of behaviors from providers, which I think is very interesting. Sometimes people will say, like, are providers the new plans? And I don't think it's a complete one for one, but I think some core competencies are starting to be shared, starting to be understood. Those kinds of things are really important. I would just say that also the Medicaid line of business has become more and more important, both for plans and providers. Lots of consolidation in that market too, as you know. Medicaid typically from the plan side is a low margin, high volume business. And so we've seen a lot of mergers, acquisitions, things like that. And so there's a pressure there too, and especially coming out of One Big Beautiful Bill. But it's had to make value-based contracting more of a contact sport for folks who are serving that population.
So I know both Brantley and you have been involved in the Medicaid space for a number of years. And right, Medicaid is state specific. Mm-hmm. And so what are you, I mean, you just touched upon it briefly, but what do you expect to see in the Medicaid space given the One Big Beautiful Bill? So on a going forward basis, what are some of the changes or pressures that you're looking to see? And then, I know it is so state specific. So let's just say in New York, what are your expectations for what's likely to happen in New York?
Yeah, great question. What I would say is, as much as Medicaid is a state-specific program, the foundations look very similar all across the country, meaning the sort of nuts and bolts of how a Medicaid program is set up. Obviously, the benefit packages look a little bit different, what's covered, what's in, what's out. Those do shift. But I think the two trends I would point to is in the One Big Beautiful Bill, the changes coming down, a slew of changes. There's eligibility, there's re-enrollment, there's specific subpopulations, there's all kind of changes. But I think if you fast forward and ask, what is that going to do? We're going to have fewer people on Medicaid, and they're going to be sicker and riskier. And so I think this is a new dynamic that since the Affordable Care Act, companies who work in the Medicaid space, the insurance companies, have been able to have populations on those programs, or what I call bolt-ons, that are actually healthier. So the margins are a little bit better on those populations, and they're able to reinvest that margin into what we would call your traditional Medicaid population. With the changes coming down from One Big Beautiful Bill, we are already starting to see those populations no longer covered by the program, which again, all of this is a big math problem, right? And so if you're losing a population that has more favorable margins that an MCO can reinvest in a separate population that has less favorable margins, I think the question does become, one, where do insurers make up that loss? And two, what does that mean for the population that is left? I will also just say, I think MCOs have gotten better at managing Medicaid populations. I don't think that they've gotten all that much better at managing the riskiest Medicaid populations. And so I guess to put a finer point on it, they're going to be thrown into the deep end of the pool very fast, and they're going to have to learn how to swim.
Yeah, no, I would just maybe add to that. I think from a global perspective, I expect provider organizations, in particular health systems, will be much more aggressive in how they're managing their Medicaid populations, given the projections that come along with the cuts of that program. So these organizations that have spent the last 10 years investing in population health capabilities, care management, data infrastructure, I think what you're going to see is those capabilities brought to bear in a way that has an impact for our most at-risk population.
Yep, absolutely. Totally agree.
So given these changes, how would you say that organizations are now approaching value-based contracting in today's climate with, strategic partnerships and alignment with other providers?
I'll start, and I'll maybe start just by pointing out the two realities that I think are really shaping the payer contracting and value-based care strategy at more of a health system level. One is, of course, as we've referenced, the projected impact of the Big Beautiful Bill. All the CFOs that I've talked to recently are preparing for and budgeting for around a 3 to 4% impact on their health system margins. So if I'm a $1 billion organization, suddenly I need to find $30 to $40 million in financial improvement. Ideally, that's not all going to come from cutting, right? So how do we address that top line revenue through a rebalancing of our reimbursement portfolio, scrutiny on participation in certain value-based contracts. I mentioned a lot of organizations that we're working with right now are moving out of smaller attributed lives contracts, certain contracts that may be focused on the commercial space. So we're seeing a lot more discipline and rigor around A, where are we going to play and how are we going to win, and then B, how do we identify and prioritize our preferred partners to go down this path with, right? Because we can put the best deal on paper possible, but if it doesn't play out and we don't have the right partners, we're seeing organizations voluntarily go out and network with your big name insurers. That's a real thing that folks have to deal with. So who are the right partners? How can we optimize kind of the enterprise revenue portfolio as a whole? And that really kind of lends into where and how are we going to participate in value-based contracting? And it's really what we're seeing is it still works. The economics pencil out in traditional Medicare, MA, and managed Medicaid, less on the commercial side. Now, having said that, if there's a competitive or strategic reason why we might want to enter into commercial value-based contracting, we absolutely should. So do we carve out certain episodes and procedures in a bundle environment? Are there narrow network opportunities, direct-to-employer opportunities? Yep. We'll never just say no all the time to commercial value-based contracting, but what I'm observing is a lot more scrutiny, a lot more strategy, and a lot more discipline around how to engage within that particular line of business on a value-based contracting standpoint.
Yeah, I think I love the concept of discipline, because I think the early days of, spray and pray, we're going to do a little bit of everything, we're going to pray and we're going to see what happens. Those are starting to be over because of these pressures. And so people are having to be much more disciplined, look back at their data. Where did they perform? Where do they think they can perform? Some of the earlier panels were talking about, what do you learn in a CMMI program like MSSP or ACO REACH that you can then bring over to another line of business? I do think that the entities that are going to win the day on this next wave, it's going to be those who are super disciplined. Absolutely.
So, do you think now that providers are really treating this as a growth lever, or are they still using it as a defensive hedge so they are prepared for the future?
It depends who the provider is.
I would say a little of both, maybe. and I think it also depends on the market too, right? It's really kind of the cross section of what is the external market environment? What's the payer environment? And, how advanced is it? There are some states, I spent several years in the state of Alabama. That's a much less progressive state because it's basically a single payer state. They have Blue Cross controlling 85% of the market. There's not as much innovation. You go to a place like Maryland with in a global budget environment, or Massachusetts where there's a lot more adoption of capitation. How you're positioning or considering value-based care as either defensive or strategic growth depends on geography to a large extent.
Couldn't agree more. I think the other thing I would just add is the folks who, and I know this is a key theme of today, the folks who got started earlier, the providers who this is not their first day in value-based care, they started maybe 5-10 years ago. We're starting to see them be market dominant players. They learned early on what they're good at, what they're not good at. They've built out their capacity. And I'm seeing more and more of those provider groups, especially on the primary care side of the house. They can now take full capitation, full delegated risk. Give me the entire premium, let me manage. And they are incredibly successful with great margins for those organizations. I think, and I'll put hospitals and health systems in this bucket, I think not all, but many saw value-based care as maybe the next population health trend. And so they paid it a little bit of lip service. They went to a conference, but they never really took it seriously. That's who I'm seeing struggle at this point because they didn't use that time to build up the capacity. I kind of call it like value-based care is a muscle. You have to learn how to do it, right? It's not because you join a gym that you get fit. It's by joining a gym and going every day, right? And so I think that's what we're seeing in the provider market. And so I agree, it has this geographic split to it, market split, and then it just has a maturity split.
100%, yeah. Great.
And I think, we've been putting on this conference for many years, and we have said from the beginning, you might be afraid to put your toe in the water, but the reality is those that did have benefited immensely, and they're now positioned for the next wave. And what payers needed or wanted 5 years ago is different than it is today. And so, Juliet, maybe you could talk about how the needs of payers have changed over time. And, what does this mean? And why do you think it's changing?
Yeah, I think payer needs have definitely changed over time. And I would say it seems to be twofold. One, it seems to be environmental. So as the market dynamics pressure plans, we mentioned Medicaid. So you're going to have fewer members on Medicaid, but they're going to be sicker. That's a pressure point that a plan has no way out of. They're going to have to either compete or they're going to have to leave a market, which we haven't seen too much Medicaid market shifts. We certainly have in Medicare Advantage. That is for sure. We've seen a lot of folks just leave markets. I think what is interesting to see is the Medicaid RFP process. So many states do RFP for those contracts. And so it is interesting to just track that over time, see who's doing well, who's not doing so well. Minus state hiccups in the RFP process, it's pretty trackable to see who's doing well. And oftentimes the way to continue and grow a Medicaid program contract like that is performance in other states. So if you're applying to be, part of the Texas Medicaid delivery system, you have to show that your contract in Tennessee actually had results. So I think this is the nirvana of value-based care was always that, outcomes would rule the day. And we are starting to see some of that happen. I also think, so those are like the pressures that they don't control. I think there's, just as much as I just said, value-based care is a muscle that provider need to learn how. We sort of forgotten all of this, that payers have also had to learn how. And there's a lot of turnover in the payer space in terms of leadership, who the support team is, and how fast they can build their capabilities. And so what I tend to tell clients is if you've met one payer, you've met one payer. They are not all the same, even though you might look at two and say, well, you're just about the same size and you have the same number of lives, you're in the same markets. It could be night and day. And so I think we've forgotten along the way that payers have had to be on this learning journey. And they're at different stages of maturity.
Yeah, I think that's a phenomenal point. And we often forget that, a lot of the perceived challenges that we're facing as a hospital or health system leadership team, payers and insurers are facing a lot of those same challenges, and maybe from a slightly different perspective. But what we're asking of leadership teams in today's environment is what kind of creative strategies or innovative approaches can we bring to the table as we renegotiate or renew payer contracts, acknowledging that we're both dealing with a similar set of issues. How can we help each other and approach it as a true collaborative partnership and not two ram heads butting together?
Yeah, I'll just pick up on that point really quickly. I think plans and providers who have really embraced the collaborative nature of value-based care have done much better. I think some people saw it as a new negotiation tactic. Let's just kind of argue about a different contract in a different way. I do genuinely, over the years, I have seen people who came to the negotiation table almost more as a joint venture. It didn't have to be a JV, but really with the same sort of intensity. They've built that relationship over time. They trust each other. When something goes wrong, when there's a blip, when there's a pandemic, right? That's when you saw a lot of those relationships tested. And so I do think folks who went in it with that collaborative spirit have done better. Other plans, I'll just say, came to it just as another negotiating tactic, and they haven't seen the positives that other efforts have.
And I think this kind of turns into something that we discussed, or I should say, Juliet, that you kind of raised earlier. And people, year after year, always raise the same questions. We have a lot more historical evidence and fact patterns to follow when it comes to Medicare, right? And we even in Medicaid to a certain context. But the commercial space is a completely different animal. In your opening, you had said, what was the phrase? Oh, commercial insurance must break before it bends. And time again, providers say, well, how do we get involved in the commercial space? What are we supposed to do? And it's a challenge. It's a challenge because fee-for-service can be so lucrative for so many. And so changing that mindset to come to a value-based perspective requires a change in culture, but it also requires a partnership with the payers. And so we have bundled payments in the context of surgery centers. We even have some direct-to-employer relationships that can be quite lucrative. How are you counseling specialists and even, other providers when it comes to engagement with commercial payers? Because the commercial payers are behind, right, the government-sponsored programs, whether they're voluntary or required.
Yeah, I think the key challenge with the commercial landscape is that it is so fractured. That is ultimately the challenge that our providers have. And you said it best. If you have a value-based contract for a commercial, one specific line of commercial business for 1,500 members, remember how I said earlier, providers need 40% of their panel to tip before they're going to be able to really engage in that way. That's a drop in the bucket. And that may mean 1 or 2 patients per patient panel. Like the math isn't mathing, as the kids would say these days. So I think a couple things have to happen. First of all, I think the cost of commercial insurance is causing shockwaves. Many, myself included, small business owners cannot face these premium hikes year after year, double digit. It's just impossible. And so I think 2 things are going to have to happen, or 2 things could happen. The bottom falls out, which just means the prices go so high, people stop buying insurance. And either that burden shifts to individual employees, which would push people back to, the Obamacare markets, or these larger, and I would say, I think it does need to start with larger employers. There's been some great work in Texas. AT&T, I believe it's 55,000 employees. I believe it's outside of Houston. Someone in Texas here in the room will correct me, but they have come to their health insurance partner and said, look, we're giving you 55,000 lives. It's a pretty, close-knit geography. Like, we just have to design this in a better way. We have to design this in a value-based way. And so I think, like I said, either the bottom is going to just completely fall out, and that will cause other pressures in the industry, or large employers are going to have to lead. And I think my optimism about large employers is 10 years ago, you didn't have a lot of value-based care experts, right? This field didn't really exist yet. I think today there's enough folks, maybe you and I, maybe that's our next gig, right? Like we might want to go over to AT&T and say, hey, you know what? I love this challenge. I have experience in these other lines of business. Let me help you, AT&T, bring down your healthcare costs. So I think there's a reservoir of talent today that did not exist 10 years ago.
Yeah, I agree. And as I reflect back on the last 10 years, I'm actually surprised that model has not taken off more, because we've seen success stories in pockets. There was a Boeing partnership. There was, Henry Ford Motor Company partnership with Henry Ford Health System. We've seen Disney partner with various health systems across Central Florida. I'm surprised that model has not taken off more. But I agree. I think that would be a great way to approach these discussions in the future.
Yeah, and I was reminded by Rushika, who started Iora, that one of his very first contracts was with the casino workers in Atlantic City, right? And so what's interesting in that model was it wasn't one particular employer. It was actually a consortium, a co-op, a model like that. And I actually have been wondering lately, is it time for that model to come back, right? Is it all the hospitality workers in the greater Atlanta area who come together and say, enough of these, like 1,000 at a time, we're all going to go in, purchasing insurance on a large scale works, but also could that drive to like a model?
Well, that's where we're going to need folks like Ed to jump in. I know I've come across these multiple employment welfare arrangements where you can pool different groups together and contract, as one larger group. But I don't know. I think that's a great thought. But there's a lot of legal detail behind that.
There is, and one of my partners is an expert in that area. But I think contracting in general, you need to pay attention to when you're contracting with any type of payer, that oftentimes you get an agreement and it's just not the face of the agreement where all the terms are, and you have to look in provider manuals and policies and procedures, and statutes and regulations, and a lot of your terms are in other places, and so it's easy to sort of lose sight of the forest for the trees. But you've got to understand where the terms are, particularly the ones that can change your compensation, can change the methodologies, your performance measures, and those things. And I think that when you're dealing with value-based contracting, you really need to remember you need to be looking at different fundamentals in terms of, like, data is very important. How often you're getting data, and do you have the data you need to modify performance during the periods that are relevant for your measurements? And but can the payer change terms on you midstream, and can they change terms unilaterally? And so, contracting is a complex subject in and of itself from the legal perspective. But I think at the end of the day, you just got to be willing to ask for what you want. You got to be willing to push. And I think it remains a very important part. I mean, contracting in its broadest sense is partnerships, which y'all are talking about. And when it comes to lawyers, it's how do you paper it? Where are the material terms and conditions? And it's not unusual in value-based contracts that things can be changed unilaterally against an individual provider. And so you want to be looking at, can I have exit provisions if my performance standards are changing or my compensation is changing, and I don't have a way to have a say in that, or if I'm not getting timely reports, or if I can't meet performance measures because the reports aren't provided in time for me to adjust and move forward. So there's a legal dimensions and there's a partnering dimensions, and you've got to have your eyes on everything. And I would say you can't lose sight of the contracts, because what we see as lawyers, that a lot of times people will just sign agreements and they don't even understand what's in the agreements until there's a problem. And then they're trying to resolve a problem. They're like, well, we didn't know this is what it said, or we didn't know that there was this thing called a policy manual or policies and procedures. And it's just, it's a very complex web. And so in addition to the strategic stuff, you need to be focused on the details and get help creating those details, so that when you go in, you really understand, your eyes are open in terms of expectations of what have I really bargained for, and what do I have control over, and what do I don't have control over.
And in my mind, I mean, when we're dealing with payer contracting, there's a host of things to consider, but you have two primary buckets: the data and then the terms in the contract. Ed and I were working on a contract earlier this week, and we get an agreement, and client says, can you look at this? And then we said, okay, where are all of these things? And before we knew it, we had 10 other accompanying documents with multiple links within those documents. And so you think you have a base agreement that might be 8 pages, but the reality is it's 100 pages when you start looking at the provider manual, the other documents, and the links that are embedded in those documents. And about last year, I remember we had an explicit conversation about whether or not the commercial payers actually had the data to enter into these contracts if there were willing providers. And the reality is they do have data. There are problems with their data. You know, Brantley and I were talking, and he actually has a technology that has robust commercial data that he can use to help his clients negotiate these contracts. And I think it would be, you know, important. Brantley, I'd love you to explain to the audience about this technology. And then I'd love to hear from both Juliet and you, and then obviously from Ed, on if you had to pick 4 terms for the audience to focus on in connection with their payer contracting, what would those terms be?
Sure, I'll touch on the price transparency and the reimbursement benchmarking. We are in the process of rolling out an updated kind of front end interface using all of the price transparency files and machine readable information that the commercial insurers are required by law to post on a monthly basis. What that ultimately is going to look like is we'll have the ability to benchmark across the full universe of procedures and codes across the entire country by provider, how organizations stack up or compare to their competitors in terms of reimbursement for common procedures across common sites of care. So kind of how that plays into the value-based care space is if we look at the data and say I'm a health system A in South Georgia, if we run the numbers and see on average hospital or health system A is reimbursed at about the 20th percentile across the board as compared to either a state or another defined peer cohort. Well, that kind of lends itself into, once we've defined the opportunity or defined sort of the comparison, how do we then approach, from a strategic perspective, renegotiation and approach the payers to become more competitive? And option A, if I'm a CFO, option A is going to be, hey, we need to be more competitive, bring us back up to the median or 50th percentile, and make those rates more competitive. Inevitably, that's not going to happen every time. So option B might be, okay, why don't we carve out certain services, as we mentioned earlier, around where can we either pick and choose for rate increases or identify certain areas where it might make sense to do episode-specific bundles. Or in that case, if you're that under reimbursed on a commercial contract, maybe it then does make sense to accept some level of risk. So that if we can continue to get paid on a fee-for-service basis and also recover some additional financial benefit through the generation of shared savings because we're already below market from a regional benchmarking standpoint, we can win in both worlds without even changing the care model, which is the hardest thing to do when it comes to value-based care.
Yeah. And what about roster management?
What was the question?
You want to take roster management?
The 1,000-pound gorilla in every room. Yeah, roster management. Really understanding who does the plan think you're responsible for? Who does the provider think they're responsible for? Even the most closely aligned, oiled partnerships, there's going to be differences in that. And that is, and maybe this gets to your question about clauses or just parts of the contract to pay attention to. That's an area where I think providers especially do need to push on plans, depending on the type of plan and how attribution upstream happens. And by upstream, I mean, we lock into these attribution methodologies that are handed to us. And I think a really good question is, no matter who you are, whether you're the plan, whether you're the provider, if it's a JV, you need to go upstream and understand, well, where is the attribution coming from and how much control do I have over that? So for example, in a Medicaid program, if you're in managed care, The state is usually going to do an auto assignment mechanism, right? So the member is enrolled in Medicaid and is auto assigned a physician without input, there's all this kind of nonsense that goes on. And so you may not have control over that. And so you need to figure out how you're going to mitigate against that. In other models, it might be a propensity of primary care services, claims-based. There's all types of different attribution models. I think what it comes down to is really understanding what's the base model, and then how are we going to agree once a month, we're going to come together and I'm going to say, these are the individuals I want taken off because X, Y, or Z, or these are the 5 individuals I want you to add because they're new to my practice.
Do you see, to that point,
Yeah.
and Brantley, to you as well, I guess we want to call these disengaged patients. If you're being attributed patients, but they're not coming into the clinic and they're not showing up, and it seems like the negotiation should be to push back, try to have those people periodically removed, like you said. And if the plan or payer doesn't want to do that, then maybe they should be paying care management fees or care coordination fees for you to re-engage those patients. I mean, it seems like that'd be a 2-step process to push back to get them out of your attribution based on whether they're showing up. And then number 2, if the payer don't want to do that, then you got to give us something to help us with the cost of re-engaging that patient. And I mean, what's y'all's experience with those sort of conversations with plans and payers?
It's such a good question, Ed, because this is where value-based payment gets really fun and in the details and data-driven. Because the knee-jerk reaction many providers will have is, I don't want those patients on my panel. Because why? You're jumping to the assumption that they are high risk, low margin. Sometimes, but I'll tell you what, 80% of the time, it's actually the opposite. These are generally healthy. The reason they're not coming in for care is they genuinely don't need it. And so you have to be careful because you might kick out, you might remove from attribution a member who actually is providing you amazing margin. And again, remember what I said, this is against a population. You need some folks who are providing margin to cover your potential losses on others. So it is a knee-jerk reaction. If I don't know the patient, let's just get him off. But you actually need a more nuanced approach. You need a data-driven
Do y'all
strategy.
do any sort of testing of prior periods, what patients would have been attributed, and figure out who are the good margins and who are the bad margins? Where do we need money to help? I mean, y'all ever see that being done?
It can depend on what the line of business is. I'll say that for sure. There's some historical information that is available, but also I think there's a lot more data that the plans have access to that can be helpful in those conversations. And I think you were going to jump in too.
Yeah. I'll go back to Heather's comment. I think we've touched on a lot of the pieces. You asked what are the 4 terms that I would focus on. I just jotted down data. What's the data that we're asking for and getting that we can actually activate and make clinical behavior change around, the attribution methodology, the DOFR, who's getting paid to do what. Are they if the payers contracted to be providing care management services and they're not doing it, we should absolutely be taking that on and positioning ourselves to be compensated for that. And then the last piece I wrote was the prior auth list. I mean, that's just become such a point of contention and a challenge across the industry. I'm aware and have worked closely with some smaller upstart health plans who part of their selling point is, we want to give health systems skin in the game, take a joint venture approach to a local market health plan solution, and B, by comparison, our prior auth list is microscopic compared to the larger payers. So we're seeing some innovation and some interesting development in terms of folks entering a traditionally archaic market and shaking things up a little bit.
Mm-hmm.
What about prior authorizations with, you mentioned if you see people pushing back and wanting some sort of substantial compliance, if it doesn't eliminate or destroy the medical necessity, that or the scope of the service provided, they give the providers the ability to correct rather than just denying claims. So you're just not having these battles over denied claims, but build in components in your contracts that make it harder just outright deny. You either have the chance to come back and recorrect the codes or basically have an appeal right, but it's based on if it was still medically necessary if it's still the same scope of service, that we shouldn't be dinged on, a huge volume of claims because somebody didn't get the coding exactly right. Do y'all see much in that area?
If there were a solution that could solve for all the challenges that you just described, I think there would be a lot of interest across the industry to take that on.
But we ought to try it in contracts. That's my point.
Agreed. Yeah. If you
Ask for it in contracts.
Well, that's
and
why
negotiate.
That's why I
so you
highlighted
make your life easier. You're not on the back end
Yeah.
going, "Gosh, did I agree to this? Look at all these denied claims and look at the cost of what it takes."
Fight to make that list smaller on the front end, embed it in the contract. That'll make your life.
And that's the legal part of this conversation is getting what you want in the written documents, and you got to understand what those documents are first. And it goes back to my beginning point: is you got to look at the whole cadre, the components of the agreement. It's just not the agreement you sign, and then understanding where you're at risk, and then ask for the things and ask for the changes and negotiations to get it, so you try to solve it before you have a problem. That's the whole art of contracting, is you want to eliminate the problems by identifying the issues and resolve them in the written contract in advance.
And that's why I think, there is this discrepancy, and there is going to be discrepancy in the data. And oftentimes when people enter into these contracts, they think they can rely on the payer's data. But that's not wise, because oftentimes their data may not be accurate. And so having your own data is key, because it will avoid problems, and also the timeliness in being able to access that data so you can properly perform. Juliet and Brantley, I assume that you have had a number of situations where either the payer's data did not comport with your client's data, or the client didn't get the data in time to correct whatever they needed to, and then it hurt them in the end. So if you could talk about what you've learned in those situations, the contract terms you wish were in that agreement, and then possibly, do you add penalties, right? If the payer doesn't give us the data within 10 days of the end of the quarter, what is our remedy? Because we're going to be losing money if we don't get that data.
Yeah, I'm happy to get started. And I think to Ed's point, there's, first of all, any organization going into value-based care needs to be extremely data literate. And where that goes, the point I'm trying to make is you need more than one type of data to do more than one type of thing. There's the data you want in the contract, spelled out in the contract, like Ed was talking about. What's the reconciliation process? What data will that be looking at versus here's a list of the data I need from the payer on a weekly basis to make care adjustments, right? And I do think that splitting those out makes a big difference, just so there's operational understanding of what data is needed for what purpose on what timeline, right? Reconciliation happens after a performance period, so I don't need that every day. ADT alerts and who's been hospitalized since 24 hours ago is something that I need every day, so I can do timely follow-up, right? So I think splitting those out, what is the data that we're going to look at for reconciliation? What is the data I need day to day to improve performance? Those need to be spelled out differently. And I think the hill that I will die on is it's the data that you need for performance, for operational needs, that does need very clear timeliness definitions. We have started to advise clients that if you are experiencing trouble with a plan, then you should absolutely, to Ed's point, write it into your next contract that there will be penalties. I've had a provider who they ended the year and they didn't have shared savings against their benchmark, but they made a non-insignificant amount of money from the provider because of the data lag. And so we had built penalties into that contract. And I think the thing I just want to say really quickly, because I know it's easy to beat up on health plans. I do it too. But I think the one thing I would just say is the data that they have and the data infrastructure that they have, that is the challenge. It's not, they're not the boogeyman. They're not sending it to you and, sitting on it and giggling in their office. 9 times out of 10, it's because their data infrastructure is old and broken and they can't actually get the data to you. And I just think front loading those conversations, to Ed's point, having those conversations before you even sign a contract to say, what are your protocols? Bring your data person. I'm going to bring mine, and we're going to have a really nerdy, in the weeds conversation about data infrastructure. And if you get to the point where you start to understand they can't actually give it to me, that is where you need to reconsider taking risk. Because if your data infrastructure guru is having a conversation and can't certify that the right kind of files are going to come through, you have no business taking downside risk.
And when you have that conversation, you need to identify with the business people, who needs what kind of data to be able to meet these performance measures, and then you need to put it in an exhibit to the contract. So it's explicit, it's clear. One of the things about contracting is that the courts tend to basically, to the extent the contract's clear and it's unambiguous, they're going to enforce the terms. And to the extent it's not clear, it's in a lot of jurisdictions it may be construed against the drafter. So you want to keep that advantage if you're the provider and you didn't draft the contract, but you're better served by defining what you want and put it in exhibits, make it an integral part of the contract, and then you have those remedies. One just quick point, we never use the word penalties in contracts as lawyers because most courts and most jurisdictions won't enforce penalties. We call it liquidated damages. You want it to be a measure of your damage. And an easy damage in a value-based contracting where you don't meet performance measures because you didn't get timely data is you waive the performance measures and you give us the money anyway. So that's sort of a remedy. Had we gotten the information timely, we could have adjusted our behaviors, but it's important to do those processes, and then on top of that, have audit rights, be able to have clear rights to come in, and there's not a black box where all this stuff is calculated out of sight and you have no idea where the numbers came from, and have clear remedies that go with that. And I think when you talk about remedies as lawyers, you can either go to court or you can go to arbitration or have some mediation. Arbitration can be very expensive, and so can the court, but at least the court, you have some leverage that it's not over necessarily when the arbitration's over. So you can flip a coin as which is the better approach, but maybe if you're a provider, it's having the option to pursue a remedy in court. But again, the starting point of contracting, we're talking about partnering, but the essence of it, when it gets to the documents and papers, you want clarity. You want to be clear. You want to make sure you've got all of your needs documented in the written agreement.
So, there's been a theme unintentionally that has come across many of the panels today, and that's been imagination. It's imagination and creativity. So I'd like to bring this panel full circle to where we started today. We were talking about payer contracting. We started this panel with strategic partnerships. And one of the things that we know is that when you have these value-based contract relationships, you have more flexibility in how you can treat the patient. And so we have a little more than 2 minutes left in this panel, and I want to take this time, maybe Juliet, Brantley, and Ed, if you'd like, to share some sort of story where you've had someone engage in an imaginative and creative relationship to provide better value care to a patient and to ease the burden on the providers. Juliet, do you want to, or Brantley?
Sure. I'll kick us off and I'll go very fast.
Yeah.
So Montefiore Medical Center in the Bronx, South Bronx, is one of the hottest and most asthmatic areas in New York State. Monty is a full value-based enterprise. They have total care capitation. And by looking at their data, they noticed that on days when the temperature in New York City went over 80 degrees, they had a ton of hospitalizations linked to COPD. And what they started to understand were these were mostly individuals living in low-income housing that did not have air conditioning units. An air conditioning unit costs $400. Monty went out, bought a whole bunch of those, used their own technicians to go into people's homes, installed air conditioning, and there you go. They saw huge reductions in ER use and inpatient from a $400 air conditioner.
Yeah, that's a great story, and I'm going to maybe take it in a slightly different direction and maybe reinforce or emphasize your points earlier around creativity and innovation. We harp so much, and we always tend to focus on here's what you need to do. Here are the boxes you need to check to be successful in value-based care and value-based contracting. I think the reality is there's really not a single blueprint for success, right? I've had the opportunity to work with some of the most successful health system sponsored ACOs in the country, And I can think of one example in particular where you look at their results, you know, their top 5 nationally, and in terms of the shared savings they're able to generate. I walk in there and I'm thinking, I'm going to learn so much. They probably have such a well-oiled machine. There was no infrastructure whatsoever. What they had was a culture that embraced quality and put primary care in the driver's seat of managing patients. I was blown away. I mean, so there's not one single formula or blueprint to succeed. Use this as an opportunity, or you know, take the time to be creative. You know, deploy models and strategies that reflect the realities of your local market and meet the needs of your providers.
Yes. So the panel is about to end, and I want to thank you, my panelists, for attending, and thank you from afar for those of you who have joined us today. Have a great day.